Hey everyone, it's your Sedative Physio Akshay Kumar and I welcome you all to this new lecture. In this lecture, we are going to discuss about the physiotherapy management and the rehabilitation protocol for the rotator cuff injury patients. In the previous lecture, we had covered about the basic introduction of the rotator cuff injury. We had discussed about the anatomical point of view of the rotator cuff muscles. Then we had discussed about the mechanism of injury, the pattern of tear, the size of tear, the severity of the tear, and at last we had discussed about the surgical approach to repair the rotator cuff injury, to repair the rotator cuff tears. Right? After those all stuffs, we have to discuss about the rehabilitation protocol and the physiotherapy management of the rotator cuff injury. Right? So in this video, we are going to discuss about the physiotherapy management, the rehabilitation protocol in detail in different stages. But before proceeding on this lecture, let me announce that we are launching our new batches of the anatomy, PT Neuro and the biomechanics upper extremity. So if you are willing to join these batches, you can just drop a DM on our Instagram or on the WhatsApp, or even you can mail us. Our team will revert you back with the details. Okay, and in the case of anatomy and biomechanics, we deal all the structures with the 3D demonstrations, with the 3D models to make it more easier and more attractive so that you can memorize all the stuffs of these two subjects. Right? So let's move on towards this lecture, the physiotherapy management for the rotator cuff injury. Starting with the post-operative session, starting with the post-operative condition. In the post-operative condition, what should be the goal? That's very important to discuss about. Like in the post-operative condition, the major goal is to maintain and protect the repair. We have to maintain the integrity of the repair. We have to maintain and protect the repair. Cannot do aggressive exercise just after the surgery, just within a week of the surgery. So we will have to maintain and protect the repair that is done by the surgeon. Right? Next, we will have to gradually work on the passive range of motion. We will increase the passive range of motion gradually. Why gradually? Again, it is related to the protection of the repair. We will not do aggressive passive range of motion, and once we will achieve the passive range of motion, then only we can move towards the active range of motion or the strengthening activities. So initially we will have to work on the passive range of motion only. Next, we will have to decrease the pain and the inflammation. This pain is one of the major barrier in the case of rotator cuff injury. If there will be pain in any patient, that particular patient won't cooperate us in any type of activity, in any type of rehabilitation work. That's why initially we will have to work on the pain to decrease and maintain the pain. Then only we can move on towards our activities. Then only we can move on towards our rehabilitation work. Right? So we will have to decrease the pain and the inflammation. Next, we will have to modify the ADL. Activities of daily living modification is also very important goal in the post-operative case. Right? What should be the management in the post-operative condition? See, first of all, the duration of the management always depend on the size of repair. Like, what is the size of repair? Now the size of repair will depend on the size of tear. It will always depend on the size of tear. In the last lecture we had discussed about the size of tear, you can check it out there. But for now, the size of tear is related to the duration of the post-operative session. Like how? For the partial or the small tear, you can also add a small. For the partial and small tear, it can go up to 3 to 4 weeks. For the medium and the large tear, it can go up to 6 weeks. But for the massive tear or the full thickness tear, it can go up to 8 weeks. But sometimes it can also go up to 10 weeks. But before starting the rotator cuff injury, it is very compulsory to make our patient understand that the rotator cuff rehabilitation is a very slow process. It is very time taking process. That's why it will take a long time. So please be assured about this to your patient, then only start the rehabilitation goal. Right? So for the massive tear, it can take up to 10 weeks. Sometimes if there is very severe condition, it can take up to 10 weeks, but usually it will take 8 weeks. Now the pain is increased, so cold therapy and electrical stimulation may be used to relieve the discomfort. As we have already discussed in the goal section, that we will have to work on the pain to decrease the pain, to manage the pain. Hence, to manage the pain, the cold therapy and the electrical stimulation works very good here. So we can use the cold therapy and the electrical stimulation to relieve the discomfort, to maintain the pain, to manage the pain of the patient. Right? Now just after the surgery, the shoulder is completely immobilized. Right? The upper extremity is completely immobilized. What should be the position of the immobilization? See, initial stage of immobilization should be in shoulder is slightly abducted. We will fix the shoulder in slightly abduction position. Elbow will be fixed at 90 degrees, and then shoulder is internally rotated, resting on the abduction pillow. See, something like this. For example, this is the trunk. For example, this is upper trunk, and See, this is the shoulder. The shoulder will be slightly abducted. The elbow will be at 90 degree, right? The elbow will be at 90 degree, and there will be a sling. There will be a sling. On this sling, the patient's arm will rest, something like this. Right. Now, why the shoulder is maintained at slightly abduction position? Why it is not maintained at neutral or the full adducted position? There is a very important reason here. The reason is related to the supraspinatus muscle. See, the slightly abducted position is preferred because it will maintain the blood flow in the supraspinatus and prevent wringing out that happens in the complete adducted shoulder. First of all, what is wringing out of the shoulder joint? Wringing out phenomena is basically a condition in which there is a loss of blood supply, there is compromised and decreased blood supply in any particular muscle. So, if we will just immobilize the shoulder joint in completely adducted position for a long time, in that particular condition, there will be some level of deficiency of the blood flow in the supraspinatus muscle. That's why to maintain the blood flow in the supraspinatus muscle, we immobilize the arm at slightly abducted position. This is the first reason. Second reason behind this abducted position is that the supraspinatus is in the relaxed position at this stage. That's why we prefer the abducted, slight abducted position, right? Now, after the rotator cuff injury, the biggest complication is the limited shoulder movement, the limited shoulder motion. So, we will have to work on the shoulder movement, we will have to work on the shoulder motion, but we cannot go directly on the active range of motion. Initially, the restoration of the passive range of motion is very important, but along with the restoration of the passive range of motion, our one of the goal is to maintain the repair also. That's why we will focus on the repair. By maintaining the repair, we will restore the passive range of motion. That's why it is mentioned that we will gradually increase the passive range of motion. The progression will be very slow. That's why I've told you that the rotator cuff injury, that the rotator cuff rehabilitation is a very slow and long process. It can take a lot of time. That's why, so we will have to restore, we will have to re-establish the passive range of motion, but with maintaining the repair. That is very important in this phase. For the restoration of the passive range of motion, passive pendular exercises are beneficial in this condition, and it will cause very little active muscle activity of the cuff. In this condition, post-surgery, active muscle contraction is totally prohibited. It is totally prevented. So, with the help of passive pendular exercises, we can go for the restoration of the passive range of motion, and it will cause very little active muscle activity of the cuff. Right. Now, supraspinatus and the upper trapezius activate up to 25%. With the help of this passive pendular exercise, this supraspinatus muscle and the upper traps activates up to 25% of maximum voluntary isometric contraction. It is, in short, it is written as MVIC. Now, what is MVIC? What is maximum voluntary isometric contraction? As the name is indicating, maximum, it means the highest. Next one is voluntary. It means the person can do it by itself. And isometric contraction, it means that a muscle's power to contract at the maximum level, the muscle's power to contract at the maximum level, that is basically our MVIC, the maximum voluntary isometric contraction. So, with the help of passive pendular exercises, we can develop about 25% of maximum voluntary isometric contraction in the supraspinatus and the upper traps muscle. That's one of the very important point to discuss about when we are dealing with the passive pendular exercises in the case of rotator cuff patient. Now, if in case this passive pendular exercise is very painful, if in case it is painful, then it should be continued, it should be discontinued, it should be stopped as soon as possible. If the passive pendular exercise is painful, then we will not continue it. Okay, if it is not painful, then only we will go for it. Apart from the shoulder joint, the rest of the joint of the upper extremity will go in the active assisted motion. Now, scapular muscle isometric is preferred here. It is given in the sideline position with protraction, retraction, elevation and depression type of movement, right? Now, the posterior and the anterior capsule adhesion is very common. In the case of the rotator cuff injury post surgical condition, the anterior and posterior adhesion is very common, right? So, we will have to go for the shoulder mobilization to prevent these two stuffs. Okay, that's why shoulder mobilization is done here, the gliding, sliding, the accessory movements are done here. Okay, so physiological and accessory movements both should be done. Here, posterior glide with passive stretching is better than passive stretching. Now we have 2 points. First is just the passive stretching. We can go for the passive stretching, and secondly we can go for the passive stretching plus posterior glide. Now if we will see the result, this will show a better result. It will show a better result as compared to just passive stretching. And what it will do, it will just prevent, it will prevent the posterior shoulder capsule adhesion. Now posterior shoulder capsule adhesion is one of the common complications that we can see after the surgery. That's why to manage the posterior shoulder capsule adhesion, to prevent that particular adhesion, we can go for the posterior glide with passive stretching. That will be a better option as compared to the passive stretching just. Now, the most neglected point is the shoulder position during the mobilization. In the rotator cuff injury, this is a highly neglected point. That's why we will have to just focus on the shoulder position during the mobilization. The shoulder should be placed at least 30 to 40 degrees of elevation. Why? Because in this position, about 30 to 40 degrees of elevation, the strain on the supraspinatus muscle is minimum. That's why we will place the shoulder at 30 to 40 degrees of elevation. Then only we will go for the mobilization. It will decrease the strain caused on the supraspinatus muscle. Why we are doing this position? Why we are achieving this position? Because our prime focus was to maintain the integrity of the repair, to just manage the repair. We have to protect the repair. That's why we are giving very less strain on the supraspinatus. We will try our level best to decrease the tension in all the muscles of the rotator cuff. We will try our level best to manage and decrease the strain that is being occurred on all the rotator cuff muscles, right? So these are the conditions, post surgical conditions. Now whenever we will go for the active motion phase, so active motion phase, depending on the tear size, immobilization can be discontinued between 4 to 8 or 10 weeks. Now if the tear size is very large, then the tear size will be also very large, and if the tear size is also very large, then immobilization will be discontinued even after 4 to 8 weeks, right? So depending on the tear size, as we have also discussed this this particular stuff in the last slide, that depending on the tear size, immobilization can be continuous. But if the tear size is very low, we can discontinue the immobilization. Like if there is very small or partial thickness tear, if there is small tear, we can just remove the immobilization. We can mobilize the patient even after the 4 weeks. We can just remove the sling. Immobilization can be discontinued. Okay, so it will always depend on the size of the tear. Okay, then only we will go for the gentle active assistive movement, right? Once the immobilization is discontinued, then only we will go for the gentle active assistive movement. During the immobilization point, we will just go for the posterior glide, the accessory movements of the shoulder, right? Once the immobilization is discontinued, then we will go for the gentle active assistive movement. Light isometric exercises should also be given at that stage. Isotonic with shoulder below 90 degrees of elevation or at 90 degree in balanced position, this can also be given to maintain the active range of motion. Here our main focus, our main goal is to just improve the active range of motion. But now one more point here, that still we are working on the active motion, still we will just focus on the size of repair, we will focus on the repair. Still we will have to maintain the integrity of the repair. Now isometric in multiple angles can be given to increase the strength, to manage the muscle integrity, to manage the joint integrity, and basically to increase the active range of motion. Initially it should be slow and controlled. The patient should watch the movement patterns. Initially the isometric contraction in multiple angles will be very slow, will be very controlled, and the patient will watch the movement pattern in the mirror. But later on we will progress it. How? In the progression, after the progression, we will not allow the patient to know, we will not allow the patient to see the direction of the force, in which direction we are applying the force. The patient won't see it, and the patient is not allowed to watch the resistance. So later on we will make this progression, but initially the patient should watch the movement patterns, the patient should know the direction of the force, the patient should watch in which direction we are giving the force. Okay, now Gentle closed chain exercises can be done to maintain this to achieve this active range of motion. Mobilization and passive range of motion will be given if range of motion is not full. In case if the active range of motion is not that much accurate, if the range of motion is not accurate, if the range of motion is not full, if there is any lag in the range of motion, then we will continue with the mobilization and the passive range of motion to achieve the full range of motion of the patient, right? Now, once the active range of motion is achieved, patient is not allowed to elevate the shoulder in shrugging position. Before the active range of motion, patient basically moves his or her shoulder, patient basically elevate his or her shoulder in the shrugging position. But once the active range of motion is achieved, we won't allow the patient to elevate the shoulder in the shrugging position. But still, if the shrug is present, if the patient is doing the shrugging type of movement, then exercise to regain the normal scapular and the glenohumeral arthrokinematics or the rotator cuff strengthening. Basically, this is very important because after the injury of the rotator cuff muscle becomes very weak. Now, there is some in majority of the full thickness tear. In the full thickness tear, we can even see the atrophy. Or in the chronic tear we can see the muscle wasting. So these all stuffs can be seen. So to regain the strength of the rotator cuff muscle is very important. Once the strength of the rotator cuff muscle is gained, the patient won't go in the shrugging position again. That's why if the shrug is present, we will have to work on the scapular and the glenohumeral arthrokinematics as well as rotator cuff muscle strengthening. That is very important. Now, for the strengthening, what can we do? Patient should be able to tolerate low level functional activities. The patient, it is very important, the patient should be able to tolerate low level functional activities. We will not just jump on the high level functional activities. Initially, we will go for the low level functional activities. Between the 12 and 16 weeks, gentle isometric should be progressed to isotonic. Initially, in the last slide, we had discussed that we will start with the gentle we will start with the gentle isometric exercise. Now, this gentle isometric will be progressed to the isotonic type of activity. Now, fatigue and burning sensation, that is very important point. This is very important point. See, fatigue and burning sensation can be desirable. Okay, fatigue, if there is fatigue or the burning sensation, it is good, it is desirable, it is okay. But pain is not. If there is pain, if there is over pain, we will stop the rehabilitation at that point. We will reassess the patient, what is the reason behind the pain, and we will work on the pain. Pain is the major barrier. I already told you that that to decrease the pain is one of the major goal and aim in this condition. So if there is pain, we will stop the rehab and we will reassess the patient that what's the cause, what's the reason behind the pain, and we will have to work on the pain for it. We can even use the muscle stimulator, the cold therapy, or as per the condition of the patient. Right now, lightweight isotonic exercises can be done. Active resistive exercises. Now, once the active motion is accurate in the patient, we can go for the active resistive type of activities, active resistive type of exercise to increase the strength of the patient. Now, TheraBand resistive exercise can also be given. Rowing activities, prone rowing activities can be given. PNF pattern with resistance, especially the D2 pattern is given, because in the D2 pattern basically the rotator cuff muscle works very strongly. That's why in the PNF patterns will be given with the resistance. What will you do? You will just go for the patterns and initially you will ask the patient, you will just train the patient that what is the pattern of the PNF. Next, after that you will just ask the patient to go for the PNF patterns and you will resist the patient's pattern, right? So in this way you can basically gain the strength in the patient's rotator cuff muscles. Then the dumbbell exercise, just to maintain the strength. Even we can go for the PRE, the progressive resistive exercises can also be done here. Now after this, some important points. In massive tear, the progression will be very slow, very slow. Why? Because if we will aggressively work on the condition, if there is any massive tear, then in that particular condition, the tear will be compromised. There will be chances that tear can occur again, right? So in massive tear, the progression will be very slow. Active movement shouldn't start before 10 weeks or more, depending on the condition. Depending on the condition, we will not start the active movement before 10 weeks. Till 8 to 10 week, we will have to work on the uh, passive movements only. In the massive tear, we are talking about the massive tear. In the massive tear, active movement shouldn't start before the 10 weeks. Till 10 week, we will only work with the passive range of motion. Patient may be pain free. It is very important point to discuss about, to think that the patient may be pain free and will gain the strength in 6 months. Within the 6 months of rehab, the patient may be pain free, the patient's ADL will be normal, the patient's strength will be normal, but still full recovery can take up to 1 year. Why it is so? Because the full recovery of the muscle fibers, the full recovery of the repair will even take 1 year, right? Even if the all the symptoms are being subsided, all the symptoms are not present, if the patient is pain free, the strength is normal, the ADL is normal, but even in that condition the full recovery will take up to a year. So the patient will have to be aware about it. And at last, the rotator cuff rehab is a long and slow process. You will have to make the patient and their attendant and their mates understand that this rotator cuff rehab will take a long time, depending on the condition. If there is the massive tear, full thickness tear, it can even take a lot of time to recover to the normal function, right? So these are all the points regarding the physiotherapy management, the rehabilitation of the rotator cuff injury. If there is any doubt in this whole stuff, you can just ask me on the Instagram or on the WhatsApp, right? And if you are interested in our courses of the anatomy, biomechanics, or the physiotherapy in neurological conditions, you can just drop a DM on our Instagram or on our WhatsApp. And we are also launching our Sedative Physio partner program. So if you are willing to join the Sedative Physio partner program, you can just drop a DM. So I will see you guys in the next lecture. Till then, be happy and keep learning.